Super. All right, sorry about that. Um,
Announce yourself from the beginning.
I just because I've already lost 5 minutes of time and I'm embarrassed about that. So the pros and cons of high drug costs, clearly, advancing the science and doing the research to get things ultimately approved is exceedingly expensive, and many, many, many drugs fail. And so if you want to allow innovation and continued testing and evaluation of new therapies, you need there to be a financial reward. And there are a lot of incentives for rare diseases that come from the high costs that you can get from treating those rare diseases, which is important. And with effective treatments, health can improve. But obviously, there are huge cons to very high drug costs. There's enormous strain on the payers, on CMS, on other commercial payers. The businesses that are ultimately paying, especially as we get to more ASO type of arrangements with payers, becomes absolutely unsustainable. It creates a whole new industry, whether it's pharmacy benefit managers or other entities that are trying to help manage costs and the use of specialty drugs, et cetera. And I hope I'm not stealing anybody's thunder here, but these are huge companies extracting a lot of dollars out of the healthcare system. And the strain on patients is so great. And ultimately, the promise of improving health just can't be realized if patients don't actually take the treatments that they want. And, this is going to be well known to anybody, but, this is the billions of dollars spent over time on prescription drugs in the United States. It's, many-fold greater than what other countries around the world pay. That's why the US is the greatest market. There's a lot of variability in the cost of drugs, gene therapies, orphan drugs, specialty drugs, and their annual cost is shown in this pyramid, whereas generic drugs, which are much more common, affect a much greater proportion of patients, are much less expensive. And yet, if you look at the net share of spending over time, the specialty drugs in yellow are continuing to grow while the traditional drugs are consuming less and less of our prescription dollars. And by specialty, I mean the costs of these rheumatology drugs, this is the average out-of-pocket cost per month by patients, depending on whether they've got, rheumatology, neurologic, cardiac problems. I mean, these are extraordinarily high costs. And in dark yellow are the specialty drugs, and in light yellow are the sort of generic or more traditional drugs. And so the growth of these high cost items is having a huge burden, and it's greatly affecting patients. This is an estimate, a survey conducted by, I believe it was the Kaiser Foundation, for the proportion of patients who report that they skip medical treatments because of the cost. And there have been efforts to try and think about policy as a strategy to affect this. And I really like this. This was a summary article in Jack that looked, when I thought about the Inflation Reduction Act, I never thought about the impact on health and the impact on healthcare costs. But buried in that is essentially an out-of-pocket cost cap by 2025 for how much a Medicare beneficiary can pay. And it's very complex who picks up the difference. But if you look at a patient with hypercholesterolemia, their out-of-pocket costs are $1,700, drops to $1,500, a savings about $130. But if you have amyloid heart disease, the out-of-patient costs, especially with the donut, are $15,000 a year for patients, and it caps to $2,000 with a $13,000 savings. And so there are complex forces at play that are contributing to this dilemma and challenge. And to sort of help us clarify all of that, we've got three phenomenal presentations. We've got a payer perspective, really talking about medication costs in the US and the drivers of insurance premium. And I'm very appreciative to have Danny Weiss from Blue Cross Blue Shield present. We'll then get the health system perspective, drug prices and shortages and their impact on patient care with Eric Boswell, who has many titles and is the Director of Acute Pharmacy Services at University Health and the President-elect of the Kansas City Health System Pharmacy Group. And then we have the pharmacy perspective. What does healthcare really cost with Matt Hardwick from Red Cross Pharmacy and Tim Mitchell, who's the owner of Mitchell's Drugstores. And so I think this is going to give us a very rich foundation for the discussions that I look forward to hearing. So thank you very much. And now, Pat, I turn it back over to you. And Danny.
Thanks, John. Aaron. Oh, Danny. Oh, no, Danny, you're up. I'm sorry.
Good afternoon. Can you hear me okay?
Yes, we hear you great.
Wonderful. I'm here to talk a little bit about the payer perspective. And as our introduction alluded to, we have a highly complex
Danny, I'm going to ask you to pause. I'm sorry.
Okay.
There you go. Okay, you're set. Yeah.
Thank you. As introduction indicated, we have a highly complex system in the United States. If this was a matter of one entity that was to blame, we would just regulate it, move on, and enjoy the fruits of our labor. But unfortunately, it's a lot more complicated than that. The first slide I really wanted to showcase here, buttons are a little bit sticky, sorry. The America's health insurance plans have aggregated where does your premium dollar go? When you put a premium dollar to your insurance plan, where does it get spent? And how does it get spent? As you can see, prescription drugs are currently the top spending percentage by far. 10 years ago, prescription drugs were closer to number 3, behind inpatient and outpatient hospital costs. The growth of new specialty drugs and some of the things in that space have shown a profound growth in pharmacy costs, and it doesn't look like it's going to slow anytime soon. When we look at our volume of distribution within the health plan and what we see in our average utilization, brand products represent about 8% of the volume of prescriptions, and they represent about 30% of the cost. These are things like GLP-1s for diabetes. These are other medications that you see, routine brand name medications that are in their patent protection. Generic medications are approaching 90% of the volume and only represent 20% of the cost. These are traditional pharmaceuticals that have expired patents, and multiple manufacturers are able to make that product at a much decreased cost. The one that is the bogey here is specialty or biologic drugs. 2% of the volume contains 50% of our cost. We think back to the previous slide, 24% of pharmacy cost. That's 12 cents for 2% of the volume. This is a abnormally concentrated portion of our cost, and it creates a large portion of our attention. But why is this area growing so much? There's a lot of focus and development from the pharmaceutical manufacturers to bring new products to market. They're also adding new indication to existing products, where they're constantly looking at what else can we be looking at with this mechanism of action. Will this rheumatoid arthritis drug also help with Crohn's? Will it help with psoriasis and expanding their market to get more utilization? And then there's the old-fashioned American increase the price. Some of these biologic products, Humira is one of the largest spend in our area. When I was researching that, 2002 when it launched, it was less than $1,000 per month. Last year, our utilization was about $8,000 per utilizer per month. So there's been a significant growth in just price increases over time. When we look at the other thing that is the scary part of our utilization, cell and gene therapy. 20 years ago, this was science fiction. Gene therapy is where we inject a plasmid of DNA into a patient who has a genetic mutation. There's no modification of their chromosome or any part of the nucleus. And when I compare this to someone that's not in medical field, I just say, imagine if your blueprints were in a vault and you're missing page 43. If I took multiple copies of 43 and left it all over the build site, people could pick it up and use it as they needed. It would not impact what's in the vault, it wouldn't impact the blueprints that the engineers developed. It's just extra information that would help us fill a gap that's missing. That's what gene therapy is. One-time treatment and gives a curative mentality. Problem is that the studies are relatively new and we don't know the duration of therapy. So while this area is exciting, we've only had a few years of experience to know that if this is going to be a permanent or semi-permanent intervention. The other one that's high cost is cell therapy. And this is another innovation that's science fiction 20 years ago. You draw somebody's blood cells and you spin them down. You take their immune cells from the patient. You train them to attack cancer. When that happens, they bring that cell back and they infuse it back to the member. They get their own blood cells back. So it is completely their own system being trained to fight the cancer. What are the costs of doing these two things? Cancer cell therapy costs us about $300,000 per treatment. Gene therapy can range for Zolgensma, 1.3 million. Some of the new products for sickle cell and hemophilia are ranging in the $4.5 million range today. And what does that mean? Well, if you can't read the numbers on the slide, 2024 is the second bar, and that's $21.8 billion in the US cell and gene therapy. We're looking at, in 10 years, exceeding $187 billion in spend. This is novel, new expenditure that's going to be expected to be borne by the US health system. And when those costs come in, unfortunately, they increase premiums and make it even more difficult to afford insurance coverage. The other thing that we wanted to really hit on is, why does pharma use direct-to-consumer advertisements? If you watch television at night, you can pretty much tell what demographic you're in by what drugs you see. There will be medications aimed at different population sects by the television show. And why do they do that? They do it because it's effective. The other thing is, what do we in the United States and New Zealand have in common? We're the only two countries in the entire world that allows pharmaceuticals to advertise freely. In most state-run health systems, they ban this practice because of the influence. And when you talk to prescribers and physicians alike, they will tell you horror stories of people coming into their office demanding the purple pill. The purple pill was a Prilosec medication used for stomach acid. Patients would come into their office and demand the purple pill. They had no idea what it was used for. They just saw an advertisement for it and thought it may improve their life. And that's a very scary realization that we have a very influential member-driven advertising that is affecting utilization. In the United States, our pharma, this is much smaller ad going from 2022 to 2026, but you can see it's increasing. The one caveat in doing this research I found is that the traditional media of television and print ads are diminishing. So if you listen to one side of the story, they'll say we're not spending as much in those segments. They're filling that with social media, online, and other advertisements electronically. So their e-marketing is increasing while their traditional advertising is decreasing for a net increase year over year. We're spending billions of dollars to advertise and tell people to go take these medications. The problem here is that this is all brand name focused. Majority of the advertisements I ever see when I watch broadcast television is specialty drugs. You don't see advertisements advocating for generics or more affordable options. And that's a problem in the United States. Why do these things all factor to drive our costs? Number one, the fragmented system of our payers. It's an open market. Medicare doesn't align with commercial payers. we don't align with Medicaid. It's a fragmented, every entity is for itself. And that diminishes our purchase value and our ability to band together to get better deal by negotiating together. From a commercial perspective, while the negotiation of the top cost drugs for Medicare is beneficial for Medicare, we just look to that to increase prices on the commercial market as these drug companies hold to their shareholders to maintain profitability. So while Medicare may benefit from that negotiation, the rest of us will end up paying more to offset those cost cuts. The other thing that it was highlighted in the previous slide set, patients are insulated from the total cost. When you cap the amount of money a patient can pay either through copays or deductible or max out of pocket, they don't see what the additional costs are. And when Medicare put a $2,000 cap, now a drug company has no incentive to keep costs affordable because a $12,000 drug can now be $25,000, can be $50,000 because they know the member will no longer pay more than $2,000 per year. And when we insulate people from the total cost of drug and they don't see that, there's no advocacy and there's no incentive to look for a better value. The regulations aren't necessarily stacked in our favor either. With patent protection, the brand name products have a litany of lawyers to protect their rights to produce product when they own the patent. And there's also a limitation in who can manufacture medications. You can't just open up a new pharmaceutical company overnight. There's regulations on production, on ingredient, on all those factors, and it becomes very difficult to be a competitor in the space. So there's limited competitors and there's limited in what they can produce. The other thing that we're stuck with is the expectation. If the FDA approves a drug, it should be covered. And there's not really a consideration with cost, value, and outcomes. And they're not usually considered in the equation. It's easy for us to look at it from a perspective of, I don't know if I would want to pay $4 million if I'm part of the group that has to pay premium. But when we look at it from the perspective of a patient, you know that a parent or a child or a family member of that child is going to insist upon that coverage. So it's easy to be rigid and say no from a distance. It becomes much more difficult from the close and the proximity. That's why a lot of plans, including ours, are really encouraged and incentivized to cover these medications despite the cost because of the greater good they present to the member. That's really the thoughts I had from a payer perspective, and I wanted to thank you for including me in today's presentation.
Danny, thank you.
Thank you.
That was terrific. Thank you so much. And next we'll have Erin Boswell. Erin, we're going to try to make this. There we go. Thank you, Erin.
Oh, can they see it on the screen?
Nope.
Nope.
Okay, I know why. I think we lost some things.
Here we go.
Yeah.
All right. Good afternoon, everyone. Like I was introduced, my name is Erin Boswell. I'm the Director of Pharmacy at University Health for acute care services, so the inpatient side. I'm also here representing the Kansas Council of Health System Pharmacists, so hopefully I can do that justice. All right, if I can get to my next slide here. There we go. So you've all heard this, you know that drug costs are rising. This is unsurprising. The total US spending on medications grew 9.9% in 2023, and this is really driven by those brand name medications like my previous speaker spoke about. The spend on brand name medications equated to $19 billion. and is projected to approach 122 billion over the next 5 years, due in large part to high launch prices. So when we're talking about these new brand name medications, it's not just the new med itself, but also medications that are new and branded, but that have now a new indication. So I showed Ozempic on here. This medication, along with the other GLP-1s, have seen a huge surge in usage due to the new the alternative indications outside of diabetes management. This is unsurprising. Drug costs has been something that health systems have had to navigate for a while now. Certainly, there are more costs now as we see those cell and gene therapies that were discussed in the previous speaker's notes. But I'm going to talk to you today about a different driver of drug costs that also is rising and posing kind of a huge challenge for us in the health system, and that's shortages. Drug shortages in 2024, in Q1 of 2024, reached their highest ever. They were over 300. So there are 300 individual drug shortages in 2024. And nearly half of those shortages started in 2022. So we're seeing shortages stick around. You know, they pop up and then we're dealing with them for a long period of time. There's been some that have hit the news. So you'll see the news article I posted there regarding the Baxter plant that was damaged by the Hurricane Helene last year. Some of these make the news, most do not. We don't hear about all 300 of these shortages and how we navigate them. And the most frequently short medications across the board are fluid and electrolytes, antimicrobials, chemotherapies, and what I call as code card medications. So the medications that are used for life-sustaining emergency scenarios. These are the ones that are most frequently short, and we can talk a little bit about why that is as I get further into my talk. There are a lot of reasons for shortages. I'm going to talk about 4 of them here. The first one I'm going to talk about is raw product shortage, and really any product shortage, but raw product, which is kind of the base, the primary part of the drug product, is if that's short, that has the most devastating consequences because manufacturers frequently get their raw product from the same places. So you may have 7 generic manufacturers of one medication, but if they all can't get the raw product needed for their production, it's going to be a shortage across the board. So we don't have a lot of options to go to in those cases. A primary example of this is around 2009 when the swine flu was around. The pig populations in China were completely decimated, and heparin, the raw product for heparin, is derived from pigs. And so we saw a massive heparin shortage at that time because that raw product was short. Another one is kind of the obvious supply and demand, but if a manufacturer discontinues their production of one medication, that supply or that demand all has to be met by the other manufacturers. So we're talking primarily of generics here, but that can cause a shortage, usually temporary, as the other manufacturers can kind of ramp up. But certainly that causes disruptions in our market. Natural disasters. This one is becoming more and more prevalent. I just showed you the slide about the hurricane, but there are tornadoes, floods, all that happen in production plants that can cause drug shortages. In the case of the Baxter plant, many of you know, but that Baxter plant in North Carolina that was damaged housed 70% of the U.S. supply of fluids. And so it was incredibly disruptive. The company was very responsive in getting some product from outside of the country, but certainly was and continues to be a challenge for us in the hospital. And then the last thing is quality problems. This could be problems like the FDA walking in and seeing a manufacturing plant where people are barefoot, or birds are flying around the plant manufacturing. These are all true things that FDA inspectors have come across. And then they need to shut down that plant until they can remediate. So that would obviously cause a shortage if they are shut down, if a manufacturing plant shut down. But this could also be like old manufacturing equipment, lack of redundancy in their equipment processes that can cause disruptions due to quality. And actually, quality is the number one reason why we see drug shortages. This is not the popular one, but this is the number one reason. 70% of our drug shortages are a quality issue or a production problem. And the FDA actually said that that the lack of market recognition for a mature quality system as a root cause for drug shortages is our biggest issue in this space. And so now I'm going to circle back to our most frequently short products, and all of what you'll see, or most of what you'll see, are generic injectable medications. And this will make sense as I explain it, but injectable products need to be sterile. So when you think about drug shortages stemming from quality issues, sterile products are very challenging to make. Much more challenging to make than like an oral medication, a topical medication. And so those different elevated standards, elevated controls, it's just much harder for manufacturers to meet those requirements. And so that's why injectables are most frequently short. And then generics, while sterile products are hard to make, they also, if they're generic, they don't have a large profit margin. They're very slim. And so manufacturers are not incentivized to have redundancy, to have quality measures in place. So we're really de-incentivizing. We're de-incentivizing by these low profit margins for these manufacturing companies a sure supply of products that are truly life-saving, that we absolutely need. And so there's the obvious problem with drug shortages, which is that we don't have a product that is needed for a patient. But then there's this expense piece too. Frequently in the hospital setting, a patient might not even know that the medication is short. And that's because of all the work that's going on in the background to either get what remaining product we can in or to identify alternatives. And all of that comes with a cost. So it's estimated that shortages add 20% to hospitals' drug expenditures. There's the price increase of the drug that's in shortage. So the drug itself is typically more expensive when it's on shortage, and certainly after the shortage is resolved, a price increase is seen of those medications. There's the substitute or alternative agents that we need to purchase, and usually those medications are increased as well. We are forced very frequently to purchase outside of our traditional suppliers. This is called the secondary market, or what some people will call the gray market. This is purchasing product from outside of our wholesalers, from companies that buy up products from either the manufacturer or the wholesalers themselves, and then sell it back to us, in some cases at over 100 times the cost. This is a real number that we saw when we were in the middle of the IV contrast shortage. We were purchasing Omnipaque at 100 times the cost. And then the training of staff to ensure that we are administering the medication safely. There's the IT component. We're now bringing in a medication that hasn't been on formulary, that we haven't used, that now we're needing to quickly add into our systems to make sure we're keeping patients safe. And then in the unfortunate event of an adverse event related to the use of alternative drugs. So while high drug costs are not new, drug shortages are not new, but the combination at which both are increasing is making an unsustainable environment for health systems, and is having a real impact on patient care. The higher drug prices, the increasing drug shortages means more cost, and that means further stretching our limited resources and ultimately jeopardizing patient access. That's my last slide. Thank you all for.
Thank you for that insight. And Matt Hardwick and Tim Mitchell. And Tim, I owe you an apology because I left an L off your name on the first.
Problem.
Our next speaker is Pharmacy Perspectives. What does healthcare really cost? To think. I don't know if this is gonna mess things up here.
I think you just opened their slides.
I'm hoping.
Share what's on the screen. So.
Did it match?
No,
No.
that's not our slide deck.
Oh,
But it also didn't match.
uh-oh. Did it show up there?
It's not there.
You have to click share screen.
Now you're sharing. Yeah,
Yep.
she's got mine up and then. Looks like.
Yeah, it's up there, but it's not on the
It's not.
online.
So I think if you go to Zoom,
I think if you do presentation or,
It's up.
yeah, it's up there now.
Well,
Just hit from the
yeah.
beginning.
John?
yeah,
Yeah. There we go.
there you go. Good,
Thank
Good.
you for your patience.
no problem. Good afternoon. My name is Matt Hartwig. I'm a pharmacist from Northwest Missouri and practice pharmacy in long-term care setting. I am a member of the National Community Pharmacy Association and very pleased to be able to present to you today about healthcare costs related to PBMs and what drives pharmacy costs.
My name's Tim Mitchell with Mitchell's Drug Stores in Neosho, Missouri, which is Southwest Missouri. Let's see here, go to our next slide. There we go. And this,
The quicker words.
oh, does it? Well, apparently I'm not a real efficient clicker, but I found a way to make it go. So anyhow, yeah, I appreciate you all having us here today. We're both members of NCPA, and so we thought we would add that on the first part of it. But we do really appreciate the opportunity to talk a little bit about it. But our primary thing we wanted to talk about today is what we feel in the community, representing community pharmacy, as what's driving the higher price of prescription drugs. And it was already mentioned earlier, PBMs or pharmacy benefit managers are one of the things that we feel like are creating a lot of the price increases over the years. Decades ago, creation of pharmacy benefit managers was a good thing. And we wanted to try to make, or the PBMs were designed to make the process of prescription drug processing for insurance companies easier. And they charged a small fee, manage the claims for the employers, government programs, and it was a good thing to get started. And if you want to pop in, just say something. So-
It made the processing of prescription claims very, very efficient. We could do it very fast.
Right. And it still is quick today because of that. Over a period of time, the PBMs are viewed as the guard dogs of the cost of the drug supply chain. That's what they tell individuals that are employers, the government, and so forth. But there's a little more to the story that's going on with that. This is a slide. There's a lot of things on here. I'm not going to go through everything, but it shows what we call vertical integration. And you can see with each one of these health systems, there is a PBM that's involved. There is an insurer. There's specialty pharmacies, there's retail brick and mortar pharmacies, mail order pharmacies, long-term care. And you can see each one of those vertical integrations over the years. And so basically they're taking care of you from, birth to death. I don't know if you want to say anything about vertical integration, Matt.
Well, yeah, the interesting thing about, and the next slide also shows how little market share there actually is. Where you at on this?
Just click right there.
So this explains how much market share 3 companies hold. You can see it's almost 80%. Danny made an interesting point about specialty meds and how they are growing. And when you talk about vertical integration, one of the things that PBMs do is not only do they hold the are they the payer, but they're also the provider of the specialty med, which happen to be maybe low margin, but very high fee. And they can control really what anybody spends on that.
Right. So like what Matt just said, there's 3 PBMs that control about 80% of all of the prescriptions in the United States. We're talking CVS, Caremark, Cigna, which is Express Scripts, and Evernorth, United Healthcare, Optum Rx, and then 21% is all the other PBMs.
And incidentally, those companies had about $700 billion in sales last year and north of $20 billion in profit.
So the impact on patient and provider relationships is really the thing that we're concerned about. And that's where we start seeing all the disparity in the drug prices between but there was actually in some of the presentations earlier talking about what drug costs were back in the early 2000s and what they are today. And the inflation of drug pricing compared to regular inflation, which we are all seeing, is skyrocketing. So indirect patient impact. There's a lot of issues that are going on. As an independent community pharmacy, we're seeing a lot of community pharmacies closing. And we're concerned about that. And one of the reasons being is decreased reimbursements and higher drug costs does not make it a sustainable business to be able to open or to continue to stay open. And so that is a concerning thing for us. You want to say anything about that?
With vertical integration, obviously the PBMs are able, since they can be a pharmacy product provider. I don't want to say they provide pharmacy service because that would be, that'd be maybe not necessarily the case, but they're allowed to skim the cream. They can take the ones that make the most per transaction to themselves, which of course leaves us with the pennies and picking up the pieces.
So factors contributing to pharmacy closures, of course, are reimbursement pressures, just what I mentioned earlier with the higher prices. And these are just some examples of stories that have happened over the last few years of individuals having to close their stores, or even groups of pharmacies having to sell to larger chains or to other independents. WAC price decreases, the IRA concerns, and that was mentioned earlier, which is the Inflation Reduction Act. There are some concerns because certainly they talk about reducing prices on medications, but there's still not any kind of regulation on how PBMs are pricing medications and how we are able to purchase the medications to be able to sell those to patients. So if you want to say anything about that.
Yeah, so in this scenario, the PBMs and the drug manufacturers have been able to insulate themselves, balancing the cost on the back of the provider, which would be us, And so therein lies why the small pharmacy is unable to handle that.
And the last thing on there is PBM restricted networks. So most of the contracts that we have, and we're not here to whine, but we're just telling the story as a community pharmacy. Most of the contracts that we have presented to us are take it or leave it contracts. And it's not uncommon for community pharmacies today to get a contract for brand name prescriptions, for some of the things that were presented earlier, for us to pay close to $1,000 for a prescription and get reimbursed anywhere from $50 to $100 less than our cost. These, again, just some examples of some pharmacies that, stories that they've closed and because of those pressures. So the next slide talks about mandatory mail order. I'm not saying mail order is harmful to anybody, although there are some concerns. And certainly Matt and I talked about this when we were putting some of these things on the slides together. What types of services does mail order provide? They're not going to provide any type of immunization services. They're not going to provide most likely same day delivery or point of care testing. So there's lots of other things that typically the community pharmacists been able to provide. Pandemic actually we played a key role in helping to immunize individuals by providing COVID vaccines and so forth as well. So, want to say anything about that? Sorry, I'm trying to ping pong it back with Matt here as well. It's kind of a little bit awkward with two people. Yes.
So, it also strikes me that if the direct mail and the local pharmacies were paying the same price for the drugs, and you could outcompete on service. I mean, what's not on your side is the education.
Absolutely.
What they take, when to take it, how to take it. The review of potential conflicting medicines, things of that sort, seems an invaluable service. It's costly to provide, and yet you're having to provide that service while paying a price for the raw product that is much greater than these vertically integrated PBMs have.
Absolutely. Yeah, I totally agree. And I appreciate that comment. Thank you. One of the things that we as community pharmacists have to deal with is we are purchasing the product, just like what you said. The PBMs are not purchasing the product. They're processing the claim and they're taking, like what Matt said, they're taking that skim off the top. Yes. Matt.
Lacey Epperson online says, I've had 2 people in the last 2 weeks come to our pharmacy to ask us to help them with the meds that were sent to them via mail order, and mail order told them to go to their local pharmacy to learn how to administer.
Imagine that. Imagine that.
Thank you, Lacey.
And us as community pharmacists, we don't turn those patients away. We take care of them. So anyhow, again, I'm not trying to whine. I'm just telling our story. So,
And I know we are whining a little bit, but the reality here is that whenever you start changing the pricing model and carving out rebates, which we're going to talk a little bit more about in the next slide, is that the dynamics of what happens to patient care is substantial, and we get to see these stories every day.
and with those closings and so forth, access becomes an issue. So another thing that we typically have to deal with PBMs, and they have lobby that's very strong in Washington, D.C. and in our state capitals, to place the blame for the rising drug prices on the manufacturer. And certainly we talked about that in a couple of the other presentations. That being said, they are raising the prices, but they're raising the prices to cover the rebates that are going back to the drug manufacturers for preferring those on the formularies. So we feel like, there's definitely some issues with the transparency of how PBMs work in this nation. And as Matt and I were talking again yesterday about, insulin, and the FTC just recently came out with the cost of insulin. And I believe it was when did Humalog come out again? 1996, it's on here. 1996, Humalog came out at $26 a vial. And I think it was just a few years ago, it was $255 a vial. So the problem is, why is that so high? And when you break it down, you follow the money and you see the manufacturer is making a little bit more. They're not making that full $255. When you break that amount down, the PBMs are getting as much as what the manufacturer is getting. And the pharmacist will get a small cut. Sometimes it's less than our cost. Now, this Humalog is actually, insulin's prices were lowered with the Inflation Reduction Act. So maybe that wasn't a good example, but there are many other drugs that can be attributed to that as well. So, but I highly advise anybody that's interested to look at this FTC report on prescription drug prices and the significant markups that's been occurring. So, you want to talk about spread pricing?
Yeah, we can do that. So spread pricing is the difference between what the payer pays for the medication and what the PBM pays the provider for the medication. So not only so this lets you know that nobody knows what anything costs, which Danny alluded to also. It's like the patient doesn't have any idea what something costs. They just get a copay, and whatever that is what it is. And since nobody knows what it costs, they can hide these dollars all over. They will contract with the pharmacy to pay at one rate. They will contract with the payer to be paid at one rate, and whatever the difference is, they get a keep. And you can see that erroneously will drive the whole healthcare spend. PBMs are the best at this. And basically, just by moving pennies on a spreadsheet, they can make millions and millions of dollars doing that. All right. Oops. I don't run as good as Tim. All right, you want to talk about a case study? Because I don't.
It doesn't make any difference. That's fine. So one of the things that we'd like to highlight, and Missouri Pharmacy Association was key in creating a case for Missouri Medicaid back in, I think it was 2006, talking about why it's important to not allow Missouri Medicaid to go to private entities, PBMs for that matter, and to manage it themselves. And what's currently happening with a lot of states throughout the nation is we're seeing that states that have moved to major PBMs that we mentioned earlier to process their prescriptions have realized that there's increased costs that they weren't expecting. Now, I will say Missouri Medicaid is still experiencing a lot of increased costs, but they have been able to save millions of dollars because they process the prescriptions themselves and not using a PBM that's skimming off that profit off of each of those claims. So the appropriate payment for pharmacist dispensing services, as well as providing, transparency and dealing with all the things that we need to do. So I'm not sure where we're at here. Yep. Absolutely.
So what this shows us is that the per member per month costs from a Medicaid where they're not penalizing the provider, not contracting below provider costs, is the same as it is for PBMs who manage theirs by negotiating lower prices. And so then you run into the spread scenario where, well, where's that additional money go? If they're not paying the provider as much and they're paying the payer is still paying the same amount per member, it's obviously going into the pocket of somebody in the middle. And that's kind of the idea behind the case study.
And on this slide, there's also some information about the Inflation Reduction Act, which we talked about. And there's still a lot of confusion about how that's going to occur in the future as more and more drugs get added. I think the initial rollout of drugs that are going to be reduced in price is 10. Then they're increasing it to 15. And where is the cost difference going? Because it sounds like what's happening is there's going to be rebates that will be brought back. The prices are going to stay the same, but rebates will be brought back behind the scenes and retroactively. Not a good cash flow scenario for a community pharmacy because they're estimating about $30,000 a month per pharmacy will have to float for the Inflation Reduction Act medications. And that's a typical pharmacy like mine. And I'll tell you, the reimbursements we're getting right now, we won't be able to keep our doors open. And then access would be decreased as well. So we'd like to highlight one of the bills that we are, and we're not going to go through the whole bill, but Senate Bill 45 in the state of Missouri is actually a bill that was heard in a committee just last week. I think Senator Travis Fitzwater, I believe, has rolled this out, has introduced this bill. And basically, it's asking for equal paying for PBMs. It's asking for a lot of different positive things for pharmacy. And we're here to highlight that. If you want to read more about it, we would highly recommend you go to a site, which I'll put on here in just a little bit. It's called stoppbmabuse.com. And that site will list all of the bills that we're talking about right now. This is a real busy slide. There's a lot of things on here, but we're going to conclude. We originally told 14 minutes, and then we said we could go a little bit longer. So hopefully we haven't gone beyond our time. Pat hasn't cut us off yet. But the PBMs are the middleman between the manufacturers and the patients. And we feel that's something that needs to be looked at very closely. They're causing higher drug prices for patients and for pharmacies, forcing the mail order and steering patients to their own retail brick and mortar stores, and then paying themselves at higher rates than other pharmacies. PBMs are not being transparent. They're hiding behind the scenes, and they're making billions of dollars doing that. PBMs will blame the manufacturers for higher drug prices, and they are extorting rebates from the manufacturers for placement on their formularies. We feel that states need to force PBMs to be transparent in their daily operations. That vertical integration we talked about, we feel like is a harmful practice. In fact, Arkansas has introduced a bill that says PBMs, if you're a PBM, you cannot own a brick and mortar pharmacy in their state because they feel like that is a harmful practice for being able to access pharmacy services. We encourage you to visit the stoppbmabuse.com. This is a site that's ran by the Missouri Pharmacy Association. If you want to learn more about some of the tactics that PBMs are doing, you can visit the modernmedicalmafia.com site. And there's a new docuseries that's on that as well that will be rolling out soon to tell a little bit more about the story. Again, I don't mean to be whining. I just appreciate you listening to our story. And we highly recommend that you speak to your state and federal legislators about your concerns about drug pricing, as well as encouraging PBM reform legislation for today, not later, but today. So, and I guess we'd be happy to entertain any other questions if anybody has any.
For sure. And online, please drop your comments in the chat or come off mute.
Yes, sir.
Can you maybe walk through and explain a little bit more how the IRA changes? You're going to have to float more.
Yeah, so the question was explain how the IRA is going to cause community pharmacies or retail pharmacies, for that matter, to have to float that $30,000 a month that I'd mentioned. So basically what they're, and again, the federal government hasn't come out with all the details just yet on this. This is just what we're being told, is the drug prices will stay the same on many of the drugs, and what they're, or at least what I pay for them. The patients will get the reduced price. The PBMs will pay at the reduced price, and then the drug manufacturers will reimburse on rebates at a later date to the community pharmacies. So there, for instance, is that, looking at that 10 to 15 drugs is, and these are not low dollar medications. These are typically anywhere from $600 to $1,500 a pop. Yeah, or more. And so, even just with an average community pharmacy like ours, that's just a small, trying to serve our community of 13,000 people, we're not going to be able to float that. So what we feel is the important way to do this is to lower the prices immediately of those drugs so that we can access those directly from our wholesalers at that lower price so that we can sell it at a cost plus a set fee for dispensing. So,
yeah, I was kind of expecting specifics of that. I was thinking more that they would be forcing it at the Part D, the plan level, right? And how they were forcing the pricing versus at the manufacturer.
Yeah. It's, from what we're being told, that is not, it's going to all appear much better on the purchasing side of the patient and the PBM, but the pharmacy will still pay at the higher prices. So it doesn't seem like a real level playing field in my opinion. Yes, sir.
Yeah, I don't know if it's different for the negotiated price drugs versus the cap, but as I understood in the cap, there was a certain proportion of the excess costs over the patient cap that was borne by the manufacturer, another borne by the payers, but I had never heard that anything was borne by the dispensers. And I had this slide about the example of tafamidis for amyloid heart disease.
Right.
You aren't going to pay any of those caps on what the patient's out-of-pocket expense would be for that, right? That seems to all be.
So the access to the medications. So I will tell you, many pharmacies that I talked to, pharmacy owners that I talked to, said that if they're going to have to bear the cost, they're not even going to be able to carry the drug in their pharmacy. So access becomes an issue. So if a medication costs $2,500 today, and it still costs $2,500 next year when the IRA drug reductions occur, but we're getting reimbursed at $1,000, we're not going to be able to float that. And that's our biggest concern, some of our biggest concerns about how this whole system's working. I'm not saying that's the only.
I think what they're going to try to do is like 340B math. 340B math doesn't work very good, truthfully.
A whole nother topic.
And Aaron alluded to 340B. Basically, what happens with 340B is originally designed to be for indigent patients. And what they do is that the entity gets to buy the drug at cheap. So like you always heard that Planned Parenthood got to buy birth control pills for a penny, where we were paying $18 for them. And so the entity buys Advair, let's say, for a penny. And then I buy Advair for $250. The entity's patient comes to me and buys the drug, and I sell it to them, and the payer pays whatever the payment is, and the entity replaces that inventory to me and keeps the difference between a negotiated price. And so now nobody knows who did what, because if that didn't sound confusing to you, it is. And so that's the kind of thing that PBMs do. The thing that's neat about really this discussion and the high IQ foundation thing scenario is that in Senate Bill 45 is that we're really going to have to discuss a new model of payment and a new model of transparency in healthcare, where the people who provide the care, are compensated appropriately. You're not going to turn insurance companies off, but the reality is that the insurance model doesn't really work for healthcare. I mean, an insurance actuary really is the politically correct term for bookie, and they get to stack the odds in their favor every time. And if you could go to a casino, if you had to go to a casino, you have to go to the casino because you have to have health insurance. You have to go to the casino and you have to play blackjack. And when you get up and you're winning, you have to stay at the table until you're back to neutral. And so we're going to have to change the idea behind the way payment is made. And this is a forum where you discuss, how do we make this fair for all players? Because we need processors, and we need the idea that some medicines are going to be very expensive to develop, and somebody's going to have to be able to, the people who can't afford them are going to have to share in the costs around people who can, or the way the manufacturers do it. And this is where these kind of high level discussions happen, because in the current payment model, it's just going to continue to get worse. Drugs are going to get more expensive. Big companies are going to get bigger, and the little guy is going to get squeezed out. And is that going to change access and impact care? Well, we believe it is going to.
So while you're talking about an actuary, do you have any actuarial experience?
Very little.
No,
Then I would encourage you to please speak to the expertise you have, because I do not know any actuaries that would be compared to a bookie.
I will tell you, that comment was made in jest, but comment well taken. Thank you. So, yes, sir.
I shouldn't have been, but I was surprised how long it took today for the word rebate to be mentioned. And I wonder if you could maybe say a little more, especially about, you mentioned the rebates back on the PBM side, but there's a lot more people involved in the rebate conversation. I just wonder if you could.
Sure. I mean,
help.
yeah, again, I don't know how much more time we have, Pat, but just cut me off when I'm.
Q&A.
Yeah. Well, I don't mean to just take the whole Q&A here. The rebates, we feel continue to raise the prices. I don't know if you remember EpiPen I think they called it Epigate or something like that. When EpiPen came out, they were charging $600, I think, for an EpiPen. It's nothing more than epinephrine in a unique device to inject. And epinephrine, how much does it cost, Aaron? Less than $5. And they were charging $600. I'm sorry, 5 cents. Yeah, there you go. I guess you want to consider the syringe and everything else to administer. That being said, the federal government got involved and said, why is EpiPen, they called Mylan on the floor and said, why is this so high? They said, well, the reason it's high is this, so what's going on is when you break that down, you see rebates involved to the PBM, you see rebates involved to the brokers, you see rebates involved to everybody in the middle. The dispenser does get a small amount of that. It's not a rebate. It's what is paid as a dispensing fee. The wholesaler gets a little bit, but we find that many times the rebates are more than what the manufacturer's making on the drug. So I don't know if, I could talk for a long time about rebates, but we do feel like a more transparent system in a NADAC plus type setting, instead of making up numbers like maximum allowable cost or AWP, which is average wholesale price. There's a lot of different acronyms out there that confuse people and really produce made up numbers. I don't know if you want to say anything about that. So did you have a question back in the back of the room? Thought I saw a hand go up. Did you have a question? Yeah.
Well, I mean, because, okay, so like there's these state bills and like, I love that Wisconsin or whatever, that's right, state, they like put the law in place to prohibit, you must, if you're a PBM, you can't also provide pharmacy services.
Oh, yeah, that was Arkansas.
Oh, Arkansas.
Yeah.
Anyway, well, so I guess where my mind is at, or my question is at is like, like how do we change this, right? Like, we all know like some of the story of PBMs and PBMs are novel to the US.
Sure.
And so like on your lesson, like, so I guess it's a lot of questions loaded in one.
It's all right.
Like, it's like, have we ever considered at a federal level looking at like what, the reference pricing model of like, France and Germany, or, so it's, to me, it's like, first of all, it's like, how do we change the big model at like a federal level? Like, why does the US focus on keeping the PBMs? And if anyone here is in a PBM, we love you too, but like, and then like the secondary question is like, a lot of these, like for the Senate Bill 45 and all these, some of these are all at state level. So I'm also very curious about what is regulated at the state versus nationally. But then my third kind of question or angle was like, I'm very curious also about, like how we don't, like, is the FTC involved? Like, why, if we have literally only 3, how is there not some sort of like?
The FTC is involved. Yeah, so I don't know if you follow the FTC, but if you want to go online and look at some of the most recent rulings, the studies that they've rolled out. Now, certainly the PCMA lobby is saying that they're not valid. And there's lawsuits going back and forth between PBMs and the FTC. That being said, the most recent one that I mentioned was the insulin studies. But right now there are a lot of bills in Washington, D.C. that are trying to get rolled out. Of course, with the new administration and all the things that are changing, there's a lot of confusion going on. But there is a lot of talk about drug prices. And President Trump has actually mentioned he wants to deal with the middlemen. Now, granted, I don't know if he knows exactly all the things that's going on with middlemen, but NCPA, which was on the first slide, the National Community Pharmacists Association, is there educating them right now about what's going on. We have congressmen and senators in DC, as well as in each of the states, that are understanding what's going on and trying to tell all the others about what's going on, sponsoring different types of bills that are trying to put regulations on making PBMs more transparent. That being said, the PBM lobby is continuing to say, if you do that, you're going to increase costs. And that scares people when you talk about increasing the cost even more. But I will say, I don't think anything they're doing right now is decreasing costs, because we're seeing nothing but increasing costs.
Right.
So,
Well, and how do you decrease their market share?
yeah,
You know,
well,
are there allowable-
you break them up, and that's what the FTC is looking at trying to do. So, yes, sir. Oh, whoever, yeah.
This is not a question
Yeah.
for you guys necessarily.
Sure.
This is an observation, and I think, this is a complex adaptive system.
Absolutely.
And as long as the rules are the same, you'll continue to get the same results, no matter how hard you try harder.
Absolutely.
You got to change the rules. Danny mentioned the 4 root causes at the outset. Number 1 is US is the only open market that pharmaceutical companies deal with. Everywhere else in the world, including New Zealand, by the way, they have to negotiate with the government for the price of the drugs. Number 2, anybody who has coverage for their medication brings in the dynamic of a charge what the market will bear.
Sure.
And number 3, anybody who has coverage for their drugs has an entitlement card.
Right.
You mentioned that too.
Everybody thinks that their card should be covering everything. Yeah.
And number 4, the politicians are feckless because of the way we influence their outcome.
So my answer to that is our system is broken and it needs to be fixed. And you're correct.
I mean, you got to get at the basic rules.
Absolutely.
And if we're not willing as a country to get at the basic rules, we should probably all just go.
Yeah. Again, I don't mean to seem as whining, but really we're trying to tell our story, and I appreciate your perspective. Yes, sir.
For you or for other folks as well, I would be curious on some comments regarding the effort that Mark Cuban is involved in the hospital system.
I was actually thinking about including it, but only had 14 minutes, and now I'm at 45 minutes now? So Mark Cuban actually started a Cost Plus, which is, he started looking at IV drugs like what we were talking about because there were shortages. And I think he realized real quickly that it's difficult to get a manufacturing plant up and running. And then he thought the idea of, and I can't speak for Mark Cuban, but just hearing his story of providing low-cost medications without using PBMs. And he's found, and I have a Cost Plus pharmacy as well that I just opened up year or so ago. And we're finding that we're saving tremendous amounts of money. I still own the traditional pharmacies as well. But we found that our Cost Plus pharmacy it operates at much less overhead because we don't have to deal with contracts and PBMs, and people are paying up front. And he did mention that like what you said, the entitlement of my card wants to pay for everything. Well, people are understanding that maybe that's not the case. With the IRA coming in and starting to kind of shift with that 2,000 cap, they're shifting some of the cost burden back on the patient. And patients are starting to shop around a little bit more. So I don't know if I can tell the whole story, but I'll tell you, I do feel like that's a valid model. Not for the expensive drugs that, but lower cost generics, which typically are uninsurable anyhow. I mean, I don't take my car to a car repair shop and use my insurance to fix it. I use my car insurance to, repair it if it's been in an accident. So I don't know if that's a good comparison, but that's how I look at it. So go ahead.
Well, I mean, so, I'm of course sensitive to the argument about cost, but so not to get political, but I think it's sort of part of this dynamic. So
absolutely,
my son has a condition with 2 medications. One's cheap, but does arguably, the research shows that it's pretty hard on his body. The other medication, much more effective, much easier on his system, and 10x or more expensive. And so, of course, the insurance company, who I can't name because they're local and represented here, doesn't want to pay.
Doesn't want to pay for it. Sure.
Expensive. So I mean, there's some fundamental questions about what we expect as consumers when we pay a premium that I think are a little more complicated than just that kind of a decision that we as a family have to make.
Sure.
So,
I don't know, do you have any thoughts about that? Well, I mean, if you pay a premium, you expect to be cared for, correct? That's a hard,
to get, so, I mean, I've been in healthcare for 30 years. So
Yeah.
I understand, I've usually been on the provider side and I understand the incentives, I understand.
right, but some of the incentives are kind of the issue.
But I think that the issue should be what's the best care,
Correct.
right? And the best care in this case is tremendously more expensive. Like, so I guess is the thing that I should just suck it up and pay for it because that's in my interest.
Well, there's a you still want to stimulate innovation, right? And that's the idea. The challenge here is that the impact, what gets lost in some of this stuff is that, we get paid based on how many prescriptions we fill, not whether or not we can carve a percentage off of a rebate somewhere. And if the drug is 10x because there's a rebate and you've got 3 players and all 3 players are rebating a different product, well, how do you know which one to be? And you can't change in the middle. You are locked in for the year. And now at the end of the year, there may be a change, but you're locked in currently. So you have to play as long as you play.
Had a question over here? Sorry.
This absolutely wonderful conversation. Thank you all so much. For all the panelists, I guess, so we heard a little bit from multiple people about how kind of patients are insulated from costs to an extent. And I acknowledge, like, certainly there's some moral hazard there with kind of what people might select, being insulated from costs. My research, though, is part of a growing body of work showing that patients want to consider cost and value when they're deciding on a treatment. Value, especially when you're looking at kind of the trade-offs that you highlighted. But it's next to impossible for patients and for their clinical teams to know what, especially like hospital administered medications are going to cost, or other treatment options for that matter, are going to cost going into a decision. And part of that, my understanding is because those negotiated prices with insurance are absolutely top secret and no one will ever know what they are. And so you can't get those costs ahead of time. I just wondered if anyone would comment on, like, that seems to be a major barrier.
Absolutely.
It's not working.
Yeah.
And
So our answer to that is we need increased transparency.
yeah,
We need increased transparency with what this drug actually costs. We can talk about so many different options, but many times I'll have a prescription that comes from a health system to my pharmacy, and it's what was on formulary. And it could have been, they thought it was affordable and we run it through, and it's not covered, but they won't cover the generic either that's available. And so when we have to find another brand name, it costs even twice as much, but that's what is covered. So we don't know. A lot of times we don't know. Now, I know the patients may get information from their insurance company, and I can't speak on that. I may let Danny comment on that, but the formularies and the pricing on behind the scenes is top secret. You're right. And we don't know that as providers. So that's a very difficult thing for us to be able to relay to the patients until we're actually filling it at the time of service. And then I go out and talk to them and I say, I'm sorry, but your inhaler is no longer covered. It's going to cost $500, but we can call your doctor and get it switched to something different. And maybe it'll be, possibly we'll have to look and see, but I don't know what the formulary drug is. Sometimes they'll tell us, sometimes they won't. So yes.
We are coming up on wrap up time.
Yeah, yeah.
Danny, did you want to?
Yeah. You want to comment, Danny?
On that one, we have seen, and we've utilized tools such as RX Saving Solutions. We're an early investor in that tool. It's now owned by McKesson, one of the only wholesale distributors in the country, but they advocate and they do formulary education as well as cost education to the consumer. So it looks at their plan cost and gives them accurate quotes on what their formulary options are and when there's a clinical interaction. They're run by pharmacists. They do a clinical and a fiscal interaction to help our members through that. On our own portal, we have access to that tool and we leverage it extensively to try to bring that transparency. So thank you for the question.
Did you have another question,
I had
sir?
a question for you. I went to Walgreens yesterday.
Oh,
To
okay,
pick up a drug for my wife, which is not covered.
okay.
And I know the magic word. You guys need to know this magic word. Is there a coupon? So I asked him, I said, is there a coupon? And he said, let me look. And he's on his computer for too long. And he comes back, he says, how's $38 sound? That's better than 200.
There's no transparency in that $200.
Tell me what happened. What was that all about?
I don't know what coupon he used, but I will tell you, there needs to be transparency in drug pricing. And I'm not saying Walgreens did that.
If I didn't say, is there?
You'd have paid $200.
$200.
Yeah, yeah, yeah. Now, we work a little differently in the community pharmacy independent setting, but I will tell you, I won't go and say, if you do this. Now, I have seen an instance, I had this just yesterday when I was dispensing a medication, ran it through, the patient has a deductible, but it was $75 and I was able to run it through on our cash price for $35. Why is that? Why is that? So thank you very much for your time.
Thank you all so much. Thank you. Thank you, everyone online. Thanks for signing on and for your questions. We'll see you in March for community health workers, opportunities and challenges.
You get